And wouldn't you say, Mason, that you were still learning even right up to the day before the Viva? Or maybe not the day, but like a week before the Viva?
Literally, I think 2 days before the Viva, we did some practices with some of the second year trainees who'd sat the year before us. And it was one of them was on coagulation testing, that what is an INR, how does the lab actually do it? I'd never studied it before, and then I got a whole Viva on it 2 days later and absolutely creamed it.
There you go.
So, one way you can be like, oh man, should I have known this before? But, any little bits, just bonus, it's all good.
Correct. And I think that's the real challenge with this exam. It's the breadth. It's the breadth that I think scares a lot of trainees. But that's where those relationships and those connections you make with consultants, other registrars, other trainees, and the interaction with them. And the more you have these connections, the more opportunity you have actually to cover the breadth that's there. Good morning, everyone, and welcome to this session on pain pathways and the progression of acute to chronic pain by Dr. Mason Habel. So for those who don't know, Mason won the Renton Prize in the most recent sitting. And looking through your notes, Mason, I am not surprised at all because your layout clearly shows that you understand the anatomy of an answer and how it progresses from a pass to a prize-winning answer. So I'm really excited today to listen to all your tips and tricks. I quickly saw the 2 and 5, and I thought that is an amazing thing you picked up. So I'm really excited to listen to what you have to say, especially how all these tips and tricks helped you memorize the breadth of concepts related to pain. Now, Mason's chosen charity is on the screen here. So it's the Women's Sport of Australia. And they espouse the values of equity and equality of women in sport and has been a source of meaningful and positive change in our communities. And that's what we're all about here. We're all about equity, equality, and positive change. So without further ado, I'm going to hand it over to you, Mason.
Fantastic. Thank you very much for the introduction, Stan, and thank you everyone for coming along. Particular thanks to anyone who's keeping their camera on during the presentation. It certainly makes it for a much more engaging presentation when I can actually see your faces. If you want to keep the cameras off, don't stress, that's absolutely fine. I'll start my presentation in a moment. It will be mostly didactic today. I understand that there's some of you guys who will be sitting the exam very shortly, but some of you who will have never covered this topic and will be sitting in 10 months' time. So I might ask a few people in the audience to give a crack at some definitions, but I don't expect you to have perfect answers because I certainly learned a few new things in the last couple of weeks when I was preparing for this presentation. So have a crack. That's what this exam is all about. You learn much more by getting constructive criticism than you do by smashing the answers out of the gate. All right, brilliant. All righty. So I titled this presentation somewhat in a bit of a snarky manner about studying efficiently and accepting ambiguity, because I think pain physiology is really, it's a tricky topic for a number of reasons that I'll get into in a moment. So a bit of some disclaimers. So why I think this presentation can still be useful to you, even though I haven't done a fellowship in pain medicine. So as Stan said, I'm a current second year trainee. I did win the Renton Prize for the last sitting of the exam, but admittedly, I was never examined on pain physiology in either my short answer questions or my Viva. But so you guys know what's gone into the background of this presentation. So I looked at all the examiners reports from the year 2000 onwards. I also looked at all the Viva stems from 2013 onwards. I went through the pain physiology chapter in all 10 of the recommended texts. So you don't have to, because it's completely unrealistic for you guys to be doing that, but not so much for me, who's now passed the exam. And importantly, I wanted to do this topic because I think it's something that I can do justice to. And what I really hope to offer to you guys is that I can give you an appropriate balance between depth and the number of hours of study which you can practically allocate to this topic, to point you towards some texts which are going to be useful for the basics, but also if you are interested and you want to get some of that greater detail, that you know where to start looking without sinking hours and hours into this topic, and to talk about a lot of the ambiguities. There's a lot of tricky terminology and a lot of conflicting explanations across the different textbooks, and I hope to try and provide some sort of context to those confusions. The agenda for today, so we'll go through some of the past questions. I'll have a bit of a rant about pain physiology. We'll talk a bit about the recommended texts, and then we'll crack into the two different short answer questions for today, which will be describing the physiology of the pain pathways and how drugs modulate the perception of pain. And then we'll have a break in between, and we'll come back with outlining the physiological mechanisms of progression from acute to chronic pain and how drugs can alter that progression. We'll have plenty of time for questions at the end, but I also very much encourage you guys to ask questions throughout. I'll try and see the chat as we're going along, but sometimes it's a bit fiddly when you're sharing a PowerPoint. So please just unmute yourselves and chime in with a question. I'm very happy with that. So some of you guys may have come across a document called the Primer for the Primary. This is about a 300-page PDF document produced by a guy called Mark Reeves, who is a previous chair of the primary exam. And he lists all of the learning outcomes across the syllabus and ranks them from high, moderate, and low importance. So he's got a couple that he ranks as high importance related to pain physiology, which is predominantly about the anatomy of the sensory pathways. And you can see that there's been a number of questions asked on that as recently as 2021, which did very well, 92.8% pass rate. So, you know, your chances of getting that asked directly again in the next couple of years are probably on the lower end, but certainly rewordings and reiterations of these topics do still come up. Alterations to physiology and perception of pain in the older patient also ranked highly. That's only been asked once before in 2014, and it was not done well. I've heard conflicting opinions from pain specialists about whether they think this was a reasonable question, but it's been asked before. It is clearly a learning outcome. It can come up again, and there are decent resources so that you can at least say something intelligent about a difficult question. The progression from acute to chronic pain and also related to NMDA receptors, which are intricately linked, that's been assessed at least 3 times in a short answer question format over the last 20 years with variable pass rates. And the injury response to acute pain has never been assessed, and I would find it, I imagine it would be a tricky one to write a fair SAQ for. What Mark ranks as moderate importance is about multimodal and preemptive analgesia. I'll cover some of that stuff today, but it's never been directly assessed in the last 20 years. And surprisingly, anatomy and physiology of pain in labor and childbirth has only been assessed once in 2017, had a pretty poor pass rate. I think that would be absolutely fair game to come up again. And if you know it once and you're somebody who does epidurals at your hospital, it sticks in your memory really well, and you can just rattle it out really nicely. What Mark considers low importance, I would potentially disagree with. So he considers prostaglandins and their role in pain physiology to be low importance, but it's been asked 3 times in the last 10 years. So definitely one that you just have to put some time into, get some memory down. And it does tend to integrate quite well with a lot of your pharmacology and a number of other areas of physiology. So I wouldn't write that off despite Mark Reeves' low importance ranking. Other things about neuropathic pain and analgesia and injury-induced organ dysfunction, they're pretty nebulous concepts that I wouldn't be committing too much of your study time to, but do a little bit of reading throughout your time. Looking at the past vibers, so most of you, I imagine, look at Mac 95 to get your SAQs and direct use model answers. It's certainly what I did during my exam prep. But if you actually go onto ANZCA networks and you open up the exam reports and you scroll all the way down to the bottom, it has a list of the past viber questions that were asked in each sitting of the exam. So scrolling through from the last 26 examiner reports, these are all of the stems that related to pain. And you can see that there's actually quite a lot. Almost every single year of pain viva comes up in some sense. And some years, 2018 and 2016, about 10 different examiners decided that they wanted to assess pain physiology in some manner during their viva. So even though, the basic SAQ has been asked recently and it's unlikely to come up again in the near future, this stuff is definitely hot viva topics. And a viva is where they can really pick apart to see if you have a good understanding, as opposed to just being able to drop a couple of buzzwords, which is quite commonly seen in this topic. So my little rant about pain physiology is it's obviously absolutely core business to what we do in anaesthetics, and yet compared to our understanding of cardiac physiology and respiratory and renal, it's probably relatively poorly understood. It is continually developing in terms of how much the field understands about it, and therefore how much you will be expected as an exam candidate to know. Some related similar things are things like Panadol's mechanism of action, or how dexamethasone works as an antiemetic. If you sat the exam 10 years ago, you might have been able to say, oh, the mechanism is poorly understood. And that might have been an acceptable response. But in the last 10 years, there's been some more research, and eventually it becomes a new benchmark standard that you need to know a bit more about that. And I think pain is challenging for that reason, because some of the textbooks are out of date compared to others, and the information changes quite a lot. Most of the textbooks are not presented in a typical structured learning plan. It's kind of just like a big dump of what lab-based research has shown. And I think inevitably that means you have to compromise on some areas and just try and build a framework and a structure that works for you to remember. There are 10 textbooks on the primary exam reading list that have a chapter on pain physiology. It is completely impractical that you guys will have the opportunity to read more than maybe 2 to 3 of those for the time. You can immediately eliminate about half of them because they've got either hardly any information or it's excessively complex. And essentially, this would be my recommendation. I think Power and Cam, which was the last edition in 2020, is probably the best, well-structured, simple introduction to this topic. There's another book, which admittedly I never used during my primary prep, called Hemmings and Hopkins. It was last published in 2005, which is quite out of date, but it has a similarly good structure and some basic level of detail to Power and Cam. When you're wanting to look for some extra information, so the grey book, the Acute Pain Management Scientific Evidence, that's literally published by ANZCA. So you can surely trust anything written in there. If you write it down in an exam, it needs to be rewarded with marks. And if someone doesn't give you marks for something you've read in there, well, that's pretty unreasonable and certainly not your fault. In terms of, there's another textbook, Hemmings and Egan, which I'm a big advocate of, and I use it a lot for pharmacology in particular. Most of the chapter is excessively detailed and not what you need to be reading, but there's just one fantastic section called Spinal Mechanisms of Hyperalgesia and Allodynia, which I would recommend. There is a website which I really encourage everyone to read. So the International Association for the Study of Pain, everyone always gives their definition of pain and then they write bracket IASP definition, but most people have never actually looked at their website. And they've got literally an entire page of definitions and terminology, and that's where you should be going for your most up-to-date definitions, because they are kind of an international consensus opinion on what is often changing terminology. There's a couple of other, for weird little topics like pregnancy, elderly, pediatrics. Certainly the Grey Handbook is a good place to start, and also Pam McIntyre, Clinical Pain Management, is a really good text. Pam McIntyre is good for some of those clinical topics, but it's probably a bit too outdated for the core physiology. So I would personally skip the chapters on the acute to chronic pain and the pain pathways from there, but it's got good dedicated sections on, the clinical approaches to chronic pain. This will be the format of today's presentation. So it's going to be a bit of a traffic light system. So green is essentially what I think is what you should focus on trying to develop your understanding around what you would hope to get most of out in a short answer question timeframe. Yellow is information that you might be able to impress somebody with in a Viva, or if you're doing well on the short answer question, you might be able to get yourself a few bonus marks by giving some extra detail and understanding. And red's going to be a bit of some discussion and explanatory notes, which you shouldn't expect to be able to write down in time, but it helps to frame your knowledge and understanding. I think one of the most challenging parts of studying for the primary exam is figuring out how much you need to know for any given topic. The examiner's reports are not always very prescriptive about the depth you need to go into. In my mind, it's not enough to know enough to write for 10 minutes, because that requires you to be able to recall 100% of the information that you studied. And the last time you looked at this topic might have been 3 months ago, and you're always going to forget a few little bits and pieces. So if you learn to, an extra 50% breadth and depth, and you have a slightly greater understanding, then when you do get those questions, you can prioritize putting in what is most important. And it also means that if you do find yourself in a Viva and the examiner starts drilling down into extra information, you can show them that you know more than just the buzzwords of some definitions. Stan will send out some feedback afterwards. This is a new style of presentation for me, so I'm very keen for your honest feedback, and it'll be anonymous, of course, and Stan will send that back to me. Let's crack in, and I'm going to start asking around for some definitions on occasion. So be prepared to unmute yourself so that's all right. So the question is, describe the physiology of the pain pathways and how drugs may modulate the perception of pain. General breakdown, this question is clearly in two parts and you cannot forget either of them. So physiology of the pain pathways and how drugs modulate. And the reason I hammer on about separating the two of those is they have previously asked just about the peripheral and central nervous system pathways. And in this case, they related to slicing your thumb open. But if you glance at this question and say, oh, great, I did that thumb question a couple of weeks ago, this will be easy. And you spend 8 minutes talking about the anatomy and then realize you've got 2 minutes left to talk about the drugs, it's going to be very challenging to score well on that question. I think for a question like this, that has two parts and is so broad, layering your answer is really important. So you need to start broad, put your headings out across a number of different pages. I would quite commonly take up 5-6 pages and just put my topic headings at the top. Then I'd go back to page 1, put a couple of dot points down for each, page 2, a couple of dot points for each, page 3. And then when you've given a decent bare bones for each section, that's when you come back and give your extra detail. Because until you've done lots and lots of practice exams, and you might only have the opportunities to do a full 15-question paper, 10 or 12 times, hopefully, throughout the time. And some people might say that's a lot. You'll find that it's very easy to get sucked in and put lots of detail into the first half of question and then run out of time towards the end. So this is how I think I would structure my answer to this. Start with the definition, talk about the first order neurons, the peripheral nerve endings, as well as the fibers. You'll talk a fair bit about the dorsal horn, which is where the money is for most of the pain questions. You'll talk about some ascending tracts, not forgetting the third order neurons, how they get up the spinal cord into the brain. And then the easy part to forget is about spinal cord and descending modulation pathways. A bit about diagrams. So this is a diagram from the Grey Handbook. That's certainly not something you're going to be able to practically reproduce in an exam. It might be interesting to look at, and it's certainly nice and colourful. Maybe this is a slightly more feasible diagram that you could try and bang out in a 10-minute question. And that's probably the simplest one I came across. But for me, I always ask myself, what does the diagram add to your answer? So for me, I would only draw a diagram if there was clear precedent in exam reports that they rewarded them well. If you genuinely think that you can save time by doing a diagram, you actually have to write less words in prose and paragraphs to explain your understanding. And realistically, you can complete the whole thing in under about 30 seconds to a minute. For me, I would not draw a diagram for this question. I tried once when I did a practice exam and it became a big dog's breakfast and I ran out of time. I think the main benefit of memorizing this diagram and having it in your head is so you don't forget about the modulation pathways and the descending pathways, and you think a bit more broadly about the anatomy. So first question, can you give me a crack at what is pain? Yeah, I'm really glad you gave me that answer because it's an out of date answer, but it's what every single person gives. So unfortunately, the International Association for the Study of Pain published an updated definition of pain in the middle of 2020. And yet, whenever you read model answers on ketamine nightmares and propofol dreams, these were made a few years ago. So inevitably, there's always going to be some out of date information. And I think this is like a great epitome of why model answers are useful for framing your understanding, but they can never be the core of your study and your understanding. Because inevitably, they're always going to be 2, 5, 7, 10 years out of date. And you need to be going back to the primary texts and up-to-date information for developing your understanding. So there's been a very slight change in terminology. Instead of described in such terms, they say, or resembling that associated with actual potential tissue damage. Not a big point, but more just, an example of why staying up to date with your study is important. So coming to the first order neuron, so the core stuff in the peripheral nerve endings, we talk about free nerve endings in the tissues, and they respond to, the buzzwords are thermal, mechanical, and chemical stimuli. And the range of chemical stimuli, these are protons in terms of free hydrogen ions. Potassium's always bad. bradykinin, prostaglandins. You see this diagram here. There's a million different chemical mediators you can remember. Pick a couple of the common ones. I think these are the ones that came up most frequently and are most practical for you to remember. I don't think you get any extra marks if you list 10 different inflammatory mediators. You better spend that time elsewhere. So these stimuli are transduced by the specialized receptors on the nerve ending. That generates sort of a local excitatory potential across the cell membrane, and then that can trigger an action potential to travel all along the nerve back to the dorsal horn. Importantly, inflammation in that area can result in what we say is a reduction in the transduction threshold, so how much stimulus or energy or input is needed to trigger that action potential, and that results in what we call primary hyperalgesia occurring out in the periphery. And even though this question isn't specifically about chronic pain or developments of chronic pain, essentially even in any acute pain, there will be some degree of both peripheral and central sensitization occurring. And that's part of normal physiology. It's when it goes on and on for months and months that it becomes abnormal. When we talk about some of the drugs that can affect this area, local anesthetics, that's an easy one to drop into this question. Non-steroidals and steroids, decreasing inflammation, will both stop those nociceptors being triggered directly, and also with preventing that inflammatory winding up process. Opioids, you can potentially mention as well. It's increasingly recognized that there probably are opioid receptors. You can see it out here on the right-hand side of the diagram in red, that are expressed particularly in times of inflammation. But that's not the key site of action for opioids, admittedly. So a bit of extra detail that, if you've got time, you can throw in some extra stuff. Here are some example channel names for the different transducers. So TRPV1, you've probably come across that at some point in your reading. That's a thermal nociceptor, so it detects heat. It is also where capsaicin or capsicum cream acts. ASIC, so acid sensing ion channel, it does exactly what it says. You'll come across TRKA, which is a tyrosine kinase receptor, and that's about nerve growth factor. And I wouldn't mention anything about mechanoreceptors because they're really poorly understood. This concept of neurogenic flare, or you might have heard of it as neurogenic edema as well, is essentially that some of these nerve endings, when they're stimulated, they actually spew out some of their own inflammatory mediators, which at this location is down here in green, substance P getting released, and they actually almost self-inflame their local tissue. And it creates this vicious cycle of self-induced peripheral sensitization. In terms of what, if someone ever asks you, why do we have opioid receptors out in the periphery? You can say, well, they don't have much of a role in normal physiology, but some inflammatory cells can produce endogenous opioids, and therefore they have an action in times of inflammation. Capsaicin is another drug you could mention here, but it's probably not the first thing you're going to write in a short answer question. So capsaicin's mechanism is a bit confusing. So it actually activates one of these receptors, causing that sensation of pain and heat, but by causing it to a low degree over a long period of time, it effectively depletes that nerve of its neurotransmitters, so that if exposed to a legitimate noxious stimulus, it doesn't have the neurotransmitters left to release. What do we mean when we say a nerve ending is free? What is a nociceptor? What actually does transduction mean in general? All right, so free nerve ending just means that they lack a perineural sheath and they don't have any specialized structures. So, at some point in your temperature physiology, you would have come across like the bulbs of Ruffini and the bulbs of Krauss. And in certain mechanical touch, there's these Pacinian and Meissner's corpuscles, all these weird specialized transducers. Basically, no first order pain neurons don't need any of those. They're just free neurons sitting in the tissues. You'll see the term nociceptor used to describe two different things. In one sense, which is probably more common, it describes the entire first order neuron, which has its free ending out in the periphery, its cell body in the dorsal root ganglia, and connects up to the dorsal horn. but you also quite frequently see the term nociceptor used to refer, to each of these individual little receptors during the on the first order neuron. So I think both are acceptable. It's just so that when you're reading through textbooks, you understand what they're actually referencing. So then we get up to the nerve fibers of the first order neuron. So the action potential that gets conducted along these different fiber types. Most important ones to get out are the A delta fibers and the C fibers. A couple of simple statements are always worth some points. A delta fibers, it's fast, it's sharp, it's well localized pain. You can say that the fibers are thick and that they're myelinated. Compared to C fibers, they're thin, they're unmyelinated, and they give you that slow, dull, aching, burning pain that's poorly localized. Now, all of these have their cell bodies in the same location in the dorsal root ganglia. And again, drugs here, local anesthetics, the main thing that you can mention at that point. Now, you notice that I didn't mention how many microns thick or how many meters per second they travel during these fibers in the green section, because I don't think that is going to be the difference between you passing or failing this question. If you remember it, it certainly adds to your answer, but don't get halfway through and stress yourself and think, I can't remember exactly how many microns it is. Just move on and come back to it and get through the rest of your answer. So personally, I don't think I remembered these numbers when I studied for the primary, but going through it, it's actually there's a couple of easy memory aids you can learn. So it's basically all just 2s and 5s. So the A delta fibers, they're the thick, fast one. They're between 2 to 5 thick, and their speed is sort of 5 to 25. Whereas the C fibers, they're less than 2 and less than 2 in terms of their thickness and their speed. And that's going to line up with the vast majority of texts, and it's certainly what an examiner is going to be happy with. A bit of extra detail about these different fibers. So C fibers probably make up about 80% of these peripheral nociceptors, and A delta fibers are only a small minority. The A delta fibers, their nerve endings tend to be more clustered as opposed to the C fibers really spread out. And again, that contributes to the poorly localized versus well localized pain. And there are subtypes that you'll come across, but I really don't think these add anything to your answer. So I wouldn't stress about learning about those. You do come across the concept of silent nociceptors in some texts, which is basically that under normal conditions, they don't do anything, but in the setting of inflammation, they become particularly relevant. And these are really abundant within the sort of the viscera of the gut, in that most of the time they won't trigger any noxious input, but in the setting of inflammation in the gut, suddenly any stretch or distension becomes detected as significantly painful. And there might be some thought that local anesthetics are particularly good at blocking the sodium channels that are involved in nerve injury. So, the voltage gated sodium channel that we talk about with local anesthetics, it's not quite as simple as one channel. There's probably like 10 or 15 different subtypes of channels, and different types of those subtypes might have greater or lesser susceptibility to local anesthetics. That's just the memory aid. So then you get up to the money, the dorsal horn. So you've got to try and get all of this information into a couple of dot points and sentences in about 2 minutes during the course of this SAQ. So importantly, the fibers enter the dorsal horn. You get a bonus point for mentioning Lassalle's tract, which is where they go up or down a couple of levels before they actually get into there. And then they synapse into lamina 1, 2, and 5. And I'll talk a bit about why I think those are the ones to remember. And then a bit about the neurotransmitters is worth mentioning. So glutamate and substance P are probably the most important ones to mention. Glutamate acts on a range of different receptors, including the NMDA receptor, but that's probably more to do with prolonged painful input and chronic pain, as opposed to AMPA, which is the most common one for sort of fast detected pain. And substance P acts on a receptor called the neurokinin 1 receptor. What's a nociceptive specific neuron, and the other, what is a wide dynamic range neuron? I'll start with the nociceptive specific. So it's high threshold in terms that pain or noxious stimuli are often described as requiring a greater amount of peripheral stimulus to activate various nerves and receptors. So these neurons, these are second order neurons within the dorsal horn, and they are only activated. The only signals that they receive are noxious input. So it's like pain in, pain out. That's all they do. Whereas the wide dynamic range neurons, correctly you've identified, you hear them discussed within the transition from acute to chronic pain, but they do have a role in normal physiology as well. So they receive pain in, but also touch in, and their outward signal is always pain. So under normal baseline physiology, when you get a touch sensation, that's not enough to activate those neurons, and so there's no ascending signal that says you're in pain. But if you get stabbed, it's still going to tell you there's a problem. But you've correctly identified in the setting of inflammation or other issues where there's sensitization of those wide dynamic range neurons, then suddenly the touch sensation can produce an ascending signal that tells your body that you're experiencing pain. You can potentially throw in a bit of extra detail that the high threshold nociceptive specific ones are mostly in lamina 1 and 2, and you generally hear about the wide dynamic range neurons being in lamina 5 that receive both the noxious input from A delta fibers and the innocuous input, which are these A beta fibers for touch input. And we'll talk a bit more about A beta fibers when we come to the chronic pain stuff as well. So this is a really nice diagram that I stole from Deranged Physiology, which is an ICU primary exam website that many of you have probably seen, and I used them for heaps of stuff. So starting on the lower left of the diagram, you've got pain coming in, you've got the cell body in the dorsal horn. This dotted line here is your Lissauer's tract, which it's going up or down a couple of levels. There's then the synapse in the dorsal horn of the same side of spinal cord. It's then crossing via the anterior white commissure. Again, just a buzz drop name you can put in there. I've altered it in red because they've actually drawn it on the posterior side instead of the anterior side of this diagram. And then you get up into the spinothalamic tract and other tracts. So when we talk about drugs in the dorsal horn, this is where the money is. So opioids, big role here. Probably about 70% of the opioid receptors are presynaptic, but they are located both pre, post, and on various spinal cord interneurons. And probably all opioid receptors have some role here. NMDA antagonists, pick your poison: ketamine, methadone, magnesium, nitrous, they're all good. They all do the job. Gabapentinoids, worth mentioning, but they're a little bit more complex. So they are antagonists at the alpha-2 delta subunit of a voltage-dependent calcium channel. We'll talk a bit more about that in the transition to acute and chronic pain. You've got direct noradrenergic agonists, so they act on alpha-2 receptors. So that's things like clonidine and dexmedetomidine, and they act both pre and postsynaptically at the dorsal horn. But then you've got sort of the indirect noradrenergic drugs, your SNRIs, your tricyclic antidepressants, and your tramadol and your tapentadol. Importantly, remembering that tapentadol does have the noradrenergic effects, but it doesn't have the serotonergic effects that tramadol has. Tramadol's a bit dirtier, whereas tapentadol's more modern, clean, doesn't make people throw up as much. Clearly this is where you're going to get most of your marks for discussing drugs, but just make sure that you spread your answer out a bit throughout the SAQ and you give a few points here or there. A few extra bits of detail on the dorsal horn. So, while most of them come through the dorsal side, there's probably a couple that come through the ventral side. And so there's this weird neurosurgical procedures called dorsal rhizotomies that some patients have for chronic pain. But unfortunately, it's probably not going to work for 12% of patients because they're going to still have some pain traffic that ascends through. When we talk about the first order neurons going up or down a couple of levels before they get into the spinal cord, there's probably some difference between A delta and C fibers, that A deltas probably go 1 or 2 and C fibers usually 3 or more. It's just another factor that produces the fact that A delta fibers give you that well localized pain, whereas C fibers give you a more diffuse impression of the painful stimulus. A couple of receptor numbers in there, name that you can potentially remember. And some extra drugs for bonus, cannabinoids probably have a presynaptic role at the dorsal horn. And I've put non-steroidals and anti-inflammatories in here. Not that I've really come across it, specifically mentioned it as such, but there's an increasing role that NMDA activation can produce the production of inflammatory mediators, specifically via COX induction in the spinal cord. And so by counteracting that part of the process, you may decrease central sensitization. So I found the lamina one of the most annoying things reading through pain physiology, because you read one textbook and it says lamina 1, 2, and 5, and the next textbook says lamina 2, 4, and 12. There's not even a laminar 12, but it just becomes so frustrating. You're trying to get a number down, you're trying to remember something, you're like, well, what's the right answer? I need to remember something, but I don't want to commit the wrong thing to memory. So just do 1, 2, and 5. I read all 10 of the texts. It is the most common answer, and it's in the grey handbook published by the College of Anaesthetics. 1, 2, and 5, and it lines up with before, that 2 and 5 rule for the A delta and C fibers. It's going to be easy to remember. The only numbers you need to know: 1, 2, and 5. Some texts get really specific about which, like they'll say, like A delta fibers release glutamate and C fibers release substance P. And then others will be a bit more nebulous, and they'll say that different fibers release a range of different neurotransmitters. It's probably that all fibers release a mixture of a number, but generally more glutamate from A delta and more substance P and calcitonin gene-related peptide, that's that CGRP, that tends to be more from the C fibers. When we talked about high and low threshold nociceptors, you will also come across that terminology applied to the first order neurons. Sometimes people call A delta fibers high threshold peripheral nerves, and people will call the A beta touch fibers low threshold peripheral nerves, but that's the less common terminology you'll come across. Can you tell me what are some of the ascending tracks from the dorsal horn to the higher centers? Beautiful. So correct, the spinothalamic tracts, that's the big one. There are subtracts, this neo and paleo spinothalamic. Personally, I thought that was a bit harsh that the examiners expected that for a standard answer in their previous exam reports. So, it gets in the green box because the exam report has specifically mentioned it. It provides that sensory discrimination of pain. It tells you where it is and how much it hurts. Simple diagram here, as I showed before, it crosses over and then it ascends up through the tract. The other tracts, there's a huge number of names. Just remember a couple of them that stick in your brain. So spino-reticular, you got spinolimbic. There's also spinomedullary. You'll come across spinomesencephalic, and that includes the spinoparabrachial, which is like a subgroup within that tract. And it's important to mention what all of those other tracts contribute to. It's things like, it's not just when you cut your thumb, it hurts. It's that you feel sad about it, your heart rate goes up, your cortisol goes up, and you don't want to cut your thumb again. Drugs to mention in this area, local anesthetics, probably the main thing for the tracts, like doing a spinal. So in terms of differentiating between the anterior and lateral spinothalamic tracts, so I used to think like neo was noxious, and so the anterior was mainly just what I think of as the spinothalamic tract. It's just A delta fibers and lots of feeling where the pain is and how much it hurts. Whereas the paleo spinothalamic tract was more about the emotional and sensory stuff, and it pretty much does the same job as all the reticular, mesencephalic, limbic, etc. It can almost is more appropriately lumped in with those. So that's your autonomic and your emotional responses. With all those names, you come across heaps of different names and subtypes. This is not an exam of neuroanatomy. It's really a physiology question. So getting a couple of points, it's really just to acknowledge to the examiner that it's there. That's just me reminding myself I'm halfway through, so I better not dawdle too much. The examiners have even said, it's recognized that there's different nomenclature in the textbooks, so they're not going to hammer you about it. Just pick a few and get them out. Then we get onto the third order neurons, going up through those tracks and into the pain matrix. The pain matrix is this really nebulous functional description. It's lots of different areas of the brain, and it's all about the perception of pain, but it also integrates with feelings, again, feeling sad about the pain, why you get a sympathetic response, why you remember not to hurt yourself again. And I've put it in a second time because I think this is one of the most commonly forgotten parts of this question, and it is really important that pain is not, by its very definition, pain is not just where and how much it hurts. It is this, much more wider concept. And then, you can potentially say, here are some drugs that affect the perception of pain. If I give somebody a crap load of propofol and volatile anesthetics, they do not perceive pain. They experience nociception and they have other, autonomic and physiological responses to that, but they do not truly perceive pain in the same way that I would currently. Similar things like ketamine, you get this dissociative anesthesia. They also have direct analgesic effects, but on the higher centers, there's some action there. I would say, please do not try to spend any time remembering the different parts of the thalamus. It is not worth your time. And again, with the pain matrix, this is a really nice table on the left-hand side from Power and Cam about some of the different areas of the higher centers and how they relate to different parts of the pain experience. But I think if you just say, here's a bunch of tracks, here's a bunch of areas of the brain, here is a bunch of the responses. You don't need to perfectly line them up with each part of the brain. It's this really interconnected, nebulous concept of pain matrix. That's why it's not an anatomical descriptor. I think you're going to get as many marks as can be awarded for just acknowledging you have an understanding of these areas. And then the easiest part, it's really easy to get here and go, great, question's done, move on to the next one. But not forgetting that you've got to mention the modulation pathways. So within the dorsal horn itself, you've got a significant amount of modulation occurring there. So there's all these interneurons. Interneurons you read in every bloody pain physiology textbook. It's like their favorite buzzword. So they act both on the presynaptic first order neurons and the postsynaptic second order neurons to have different effects. So you can alter how many neurotransmitters get released from the first order neuron to determine if you're going to increase or decrease the signal. And on the second order neuron, you can either dampen it down or make it more excitable. So it's more likely to be triggered when it receives an input. And importantly, the A beta fibers, those fibers transmitting innocuous or non-painful touch sensation, they also come in here, and they kind of have a side pathway that they come in, and they depress some of the nociceptors as they're coming up. I generally think of the spinal cord as a long, skinny brain. It's not just like a highway that sends information upstairs and downstairs. It's much more complex than that. Can you show me any parts of the brain implicated in descending pain modulation? And do you know what neurotransmitters are commonly implicated in those pathways? I'm going to provide, the understanding of this structure that I've got from reading over the last couple of weeks. I think putting the periaqueductal grey and that RVMM, or the rostroventromedial medulla, I kind of lump them together because in most diagrams, there's the pathway that says those. Occasionally the PAG is identified as having direct connections down to the spinal cord, but the vast majority of the time its connections go via the rostroventromedial medulla. Before you even get to those levels, you get inputs from your higher centers, from your amygdala, which is lots of emotional input, your hypothalamus for lots of autonomic control, and you also get inputs from the ascending pain pathways that feed into the periaqueductal grey. That goes down into the RVM, and then that has projections to the dorsal horn. It's mainly serotonergic fibers from that side, as I'd read. The fact that you've read about on cells and off cells is very good. I didn't mention it in my notes because while it is discussed, it's never discussed with enough certainty or detail that I personally would ever have felt confident writing in an exam. It's probably, one of these slowly developing, was once theoretical, is now slightly better understood. And if you throw that in a viva that you've read about this, you're definitely going to impress somebody. But it's not something I would personally put in a short answer question at this stage. The locus coeruleus, good. That's the other big buzzword to mention. It kind of stands on its own in most diagrams, and it tends to project noradrenergic fibers down into the dorsal horn. These are these big diagrams that you see and you're trying to read through that and go, oh God, what's the pathway? That's my diagram, which is on one side, you've got the PAG and the RVM, and the other side, you've got the locus coeruleus, serotonin on one side, noradrenaline on the other. That's as much as I think you can get from any of these big things. In terms of drugs, so the periaqueductal grey, you read all the time that it's truckloads full of opioid receptors. And so by opioids acting there, you can increase the outflow from this pathway. In terms of the different tracks that they run through, so the dorsolateral funiculus, so there's probably a dorsal and a lateral funiculus that have different subtypes. That's the tract. It's if you write it down, fantastic. Don't stress yourself if you can't remember another weird name. Importantly, serotonin is a bit of a mess. So it's been recognized as having both pain excitatory and pain inhibitory effects. So it just doesn't seem to work as well, which, in my mind, it's like when you give patients SSRIs for their pain versus when you give them a ton of dexmedetomidine or clonidine, the noradrenergic ones tend to work more reliably, whereas all those other antidepressants are a bit hit and miss with certain patient groups. And it also helps me to remember tramadol's metabolites, which is a shocker to remember. But if you can find a way to reinforce your pharmacology with some of this physiology, it just means your knowledge from one topic can build into another area. So going more into the opioid stuff, opioids, they act on G inhibitory, G protein coupled receptors. So you say, wait, if they've got receptors in the PAG, how is that going to increase the outflow from that system? Well, as Charles has thrown about, there's probably some on cells and some off cells, and it's probably that the opioids inhibit an inhibitory interneuron. And that's always the get out of jail free card for neurophysiologists when they're trying to explain this stuff. Occasionally you read about clonidine and dexmedetomidine, and people attribute them as having an action on a higher center other than at the dorsal horn. And there's often discussions that it's probably related to the locus coeruleus. Again, these drugs tend to act at alpha-2 receptors, which are also G inhibitory receptors. And the same argument as the opioids, how does depressing the locus coeruleus have an action to increase descending pain modulation? It's not well understood. And I had spent literally hours during my primary study trying to find a clear answer for this. And we ended up getting a whole exam question on dexmedetomidine, which I wasn't mad about, but I don't think it's worth stressing about at this point. Just say it may have some actions higher up. And there's probably subtypes of alpha-2 receptors if you were ever trying to pin your hat on something. There's just my summary of tramadol of how I remembered the different parts, which will be in the notes. So I'll send you guys out. Occasionally you'll come across all these other names with it, like the nucleus rafamagnus, the nucleus dog's breakfast, all these big words that you really shouldn't be trying to remember. They're all subgroups within the rostroventromedial medulla. So just say RVM and save yourself some hassle remembering the big names. But that's SAQ number 1.
That was very comprehensive, Mason. I'm gonna ask you a question.
Of course.
This is such a big topic, and let's say hypothetically, I'm gonna cut down your writing time to 5 minutes. Okay.
Yep.
So you've only got 5 minutes to write an answer. Would you choose breadth or depth for this answer?
I think for any answer in the primary exam, you start, in my mind, breadth gets you the pass and depth gets you the 3s, the 4s and the 5s. In no way, if you write a perfectly detailed 2 pages on half the question and you ignore the second half of the question, can you pass that question? So if I ran out of time or I got distracted and I only had 5 minutes left, I would put the headings out for the entire structure of the question, and then I would fill in 2 dot points in each and see if I had any time left to fill out extra detail. I would just start, I'd say, free nerve endings in the periphery, mechanical, thermal, and chemical stimuli. I'd maybe mention about the effects of inflammation. You say your different fiber types, A, delta, and C fibers, thick, thin, fast, slow, just drop some buzzwords in there. You get up to the dorsal horn, you say you've got the dorsal root ganglia, you've got Listauer's tract, you then get into lamina 1, 2, and 5, because they're the only numbers you need to remember. You maybe drop in about wide dynamic range neurons and nociceptive specific neurons. You throw out some neurotransmitters, glutamate, substance P. You move on to your tracts, you say spinothalamic tract, but don't forget your extra tracts. You've got, spinal limbic, spinomedullary, spinoreticula. Yep, that's enough, move on. You say your higher centers, you've got your thalamus, your primary somatosensory cortex, and then you've got the pain matrix, which includes not just the localization of pain, but also the sense, the emotional, autonomic, and other effects, and then just tag on about your modulation and descending pathways at the end.
Fantastic. So I think that should be able to get you the 2 out of 5, and then just putting in a bit more detail in there will get you the 3. And obviously the other 5 minutes is about putting all those extra details in. So,
and in my mind, I think if you forgot even one of those sections, and you had, if you had a good amount of detail, I'd imagine you'd still be able to squeeze it too. But if you had the basic level of detail and you forgot even a single section, it's hard for the examiner to say that you the entire pathway.
Yes. Yeah. And looking at your table here, you would say, I would say there would be, so you need the definition of pain. I think that's really good. But then there's 5 core things that the candidate should write, which is the description of the first order and the peripheral nerve endings. And then after that, talking about the dorsal, what happens at the dorsal horn Lascelles tract, talking about the ascending tracts, talking about the third order neurons, and then finally the 5th one will be descending modulation. Is that fair?
Yeah, and I'd potentially just put modulation in general, because it's both the descending tracts, but acknowledging that the spinal cord does lots of its own modulation, even in the absence of input from the higher centers.